Hi guys. This is Dr. Silver. Today I'm going to be talking about the pathogenesis and microscopic features of endometrioid carcinoma of the uterine corpus. To start off, let's look at a real-world case. A 36-year-old female presented with dysfunctional uterine bleeding. On ultrasonography, septate uterus and endometrial hyperplasia was suspected. As a result, magnetic resonance imaging was recommended. On MR image, a septate uterus with both endometrial thickening was noted. She received simple hysterectomy with bilateral salpingectomy. This is a low-power microscopic view of the patient's endometrium and myometrium. Endometrium is thickened with increased gland-to-stromal ratio, which is a defining feature of endometrial hyperplasia. Irregularly distributed cystically dilated glands are easily noted. There were also foci with densely packed small glands. When endometrial hyperplasia is suspected, it is important to see the nuclear features on a high-power view, as it is critical when differentiating between endometrial hyperplasia without atypia and endometrial intraepithelial neoplasia, EIN. 1/4 to 1/3 of women with a biopsy of EIN will be diagnosed with cancer at immediate hysterectomy or during the first year of follow-up. So it is crucial to check the presence of nuclear atypia. When deciding whether there is nuclear atypia or not, it is easier if you find glands with relatively little atypia. On the upper left-hand corner, nuclei look like those of normal proliferative endometrium. Pseudostratified columnar cells with oval nuclei, vesicular chromatin, and multiple small nucleoli are seen. On the other hand, glands in the right-hand corner shows loss of polarity with round nuclei and prominent nucleoli. Once EIN is spotted, it is important to see if there is stromal invasion. Because there is a significant morphologic overlap between EIN and endometrioid carcinoma. Sometimes it is only the presence of invasion that can draw a line between EIN and invasive carcinoma. In another slide, a focus with back-to-back glands was found. There is a sharp contrast between left and right areas. On the right side, there is no stromal area between glands, which can be seen as stromal invasion even in the absence of myometrial invasion. On a high-power view, squamous morels are easily seen, which are frequently found in low-grade endometrial carcinoma. To sum up, this was a perfect example of an endometrioid carcinoma arising in a background of endometrial hyperplasia with atypia. Let's go over the pathogenesis briefly. Endometrioid carcinoma typically arises in the setting of endometrial hyperplasia, and, like endometrial hyperplasia, is associated with conditions in which unopposed estrogenic stimulation of the endometrium occurs. It can be due to anovulation, increased estrogen production from endogenous sources, or exogenous estrogen. Associated conditions include the following: obesity, menopause, PCOS, granulosa cell tumors, excessive ovarian cortical function, and prolonged administration of estrogenic substances. Sequencing of the genomes of endometrioid carcinomas has shown that the most common mutations act to increase signaling through the PI3K-AKT pathway, which is a hallmark of this particular tumor type. In hysterectomy specimens containing both atypical hyperplasia and carcinoma, identical PTEN mutations have been identified in each component, supporting the view that atypical hyperplasia is a precursor to carcinoma, and that PTEN mutations occur before the development of overt carcinoma. Mutations in the PTEN tumor suppressor gene are found in 30% to 80% of endometrioid carcinomas. PIK3CA, an oncogene that encodes the catalytic subunit of PI3K, harbors activating mutations in approximately 40% of endometrioid carcinomas. PIK3CA mutations rarely occur in atypical hyperplasias, suggesting that mutations in PIK3CA play a role in malignant transformation. Mutations that activate KRAS, which also stimulates PI3K-AKT signaling, are found in approximately 25% of cases. Loss of function mutations in ARID1A, a regulator of chromatin structure, occur in approximately 1/3 of tumors. Of interest, ARID1A is also frequently mutated in ovarian endometrioid and clear cell carcinomas, tumors that arise within endometriosis. PI3K-AKT signaling augments expression of estrogen receptor-dependent target genes in endometrial cells. Type 1 endometrial carcinomas are somewhat unique in that individual tumors may harbor multiple mutations that increase PI3K-AKT signaling, suggesting that tumor development and progression is fostered by successive increases in signal strength. Other commonly observed mutations in endometrioid carcinoma disrupt genes that are required for the maintenance of genomic stability, presumably acting in part to create a mutator phenotype that increases the rate of acquisition of mutations in oncogenes and tumor suppressor genes. Defects involving DNA mismatch repair genes are found in about 20% of sporadic tumors, and are particularly prevalent in endometrial carcinomas arising in women with hereditary non-polyposis colorectal carcinoma syndrome (HNPCC), also referred to as Lynch syndrome. In sporadic endometrioid carcinoma, loss of expression of DNA mismatch repair genes is commonly caused by epigenetic silencing via promoter hypermethylation. A small subset, less than 10% of endometrial carcinomas, have mutations that disrupt the proofreading function of DNA polymerase epsilon, encoded by the POL-E gene. These tumors have a remarkably high burden of somatic point mutations. In approximately 50% of poorly differentiated carcinomas, loss of function mutations in TP53 are present. Because TP53 mutations are lacking in the vast majority of well-differentiated endometrioid carcinomas, these mutations are thought to be late events involved in tumor progression. These are the textbook images of precursor lesions of endometrioid carcinoma. On the top is endometrial hyperplasia without atypia, showing glandular crowding and cystic glandular dilation, with cytologic features similar to proliferative endometrium. On the bottom is EAHEIN, which is composed of complex patterns of proliferating glands displaying nuclear atypia. References are as follows. Thank you for listening. If you liked the video, subscribe Dr. Silver's Pathology. See you next time.